who's going to talk about frontline small cell lung cancer. Dr. Che is a co-director of the Early Phase Clinical Trials Unit at Northwestern in the Department of Developmental Therapeutics, and he is his focus has been primarily lung cancer, but he is involved in biomarker directed trials and precision medicine. So Dr. Che, go ahead.
Thank you. Thank you for the kind of introduction. So tonight we're going to talk about frontline small cell lung cancer. And all right, I know. So these are my disclosures. And we're going to talk about the current standard of care, frontline small cell lung cancer treatment. We're going to talk about the 2 pivotal trials that allowed for approval for 2 immunotherapy chemo combinations. So this is the frontline landscape, and it talks about whether patient has brain metastasis, whether patient has any symptomatic disease, including spinal cord compression. But assuming that there's decent performance status with no urgent symptoms to address, NCCN currently endorses this regimen as preferred regimen, and those are carboplatin plus atezolizumab and carboplatin plus ato plus durvalumab regimen. And you have other regimens that you can consider, but the preferred are the 2 main regimens. And these are really breakthroughs that happened in this field of small cell after 3 decades of limited progress, of having almost like median overall survival of less than 10 months. We've come to have both trial leading to median overall survival of 12 to 13 months with the help of addition of immunotherapy. For Caspian, it's durvalumab. Empower 133, it's the atezolizumab that was added, and both happen to target PD-L1. And they have been FDA approved 1 year apart, starting from atezo then to durva recently. And I'm going to start talking about the Caspian trial first. It is a global randomized active controlled study. You notice that there is no placebo, but you have 1:1:1 randomization between 3 arms in extensive stage small cell lung cancer. And they did allow for asymptomatic or treated and stable brain mets. So one arm is durva plus tremi plus EP. This is the platinum plus etoposide. The next arm is durva plus EP, and you have control arm EP. And there is a maintenance arm, durva, in the 2 combination cohorts. Durva was given Q4 in the maintenance, while it was given Q3 in the combination. And for Caspian, there's 1 single primary endpoint, which is overall survival. These are the baseline characteristics. Brain mets were present about 10 to 14% in each population. Treatment exposures were pretty similar, but what's interesting is EP group had more than half of patients received up to 6 cycles, while combination almost none received the total of 6. But most patients received at least 4 cycles. So this is the updated overall survival that was presented recently. And here you can see median overall survival 12.9 versus 10.5. Durva combo versus the control arm EP. And you can see that curve continues to separate up till the third year, 22 versus 14% difference in overall survival. Here you can see that almost all, not almost all groups have benefited from addition of durvalumab, including the brain mets, with or without. And this is the overall survival group. It was presented as a poster at ASCO last year, and you can see that curve separates for both groups, above with and below without brain metastasis. Here is the updated progression-free survival. Also, you could see the hazard ratio is still 0.8 with statistically and clinically significant p-value. Here is the updated confirmed objective response. Durva combo showed objective response rate of 67 versus 58 in EP arm. And duration of response, you can see that the curve nicely separates. Although the median is same for both, it kind of separates later on. So this is the quadruple, the Durva, Tremi plus EP versus EP data that was presented at the ASCO last year. And as you can see, there seems to be some separation. The p-value that was assigned for this specific analysis actually was larger than the cutoff assigned. So it wasn't statistically significant. PFS and confirmed objective rate for the quadruple versus EP is presented here, similar. And this is the overall survival for all three arms. You can see here clearly there's not much added benefit of adding tremelimumab here, as you can see. This is the updated duration of follow-up, 25 months. It's a pretty good follow-up here. So summary is that first-line durvalumab plus EP versus EP, there is a survival benefit of 25% reduction in risk of death. 2-year overall survival, 22 versus 14%. Durva combo versus chemo only. And this was, still maintaining similar overall survival hazard ratio of 0.75 from 0.73. So what's unique is it allowed up to 6 cycles of EP and use of PCI. There's a flexibility of platinum choice, carbocis. Addition of tremelimumab really did not add much in terms of improving outcome. There was no concerning safety signals observed. Now we'll move on to Empower 133. So this is also a double-blind randomized, but this is placebo-controlled. You can see atezo versus placebo in the maintenance arm. And it evaluated carbo, not cis, etoposide, atezolizumab, also allowing for asymptomatic brain mets here. And here, contrary to the single overall survival endpoint in Caspian, here is co-primary endpoint of overall survival and PFS. So these are the baseline characteristics. Brain mets were present and comparable numbers. They have overall survival initially reported as 0.7 hazard ratio, so 30% in reduced risk of deaths, and median overall survival of 12.3 versus 10.3 combo versus control arm. 12-month overall survival was different, 51 versus 38%. So pretty meaningful difference here. And PFS continues to show difference at each landmark time points with hazard ratio of 0.77, as you can see here. Confirmed objective response rates, as you can see, are similar here between the two arms. And it seems that apart from the small number of brain mets that all groups seems to be benefiting from addition of atezolizumab. Here is the safety summary, which really does not show anything out of what we expect. Here is the updated overall survival with follow-up 22.9 months reported at ASCO 2019. So 12.3 versus 10.3 with a hazard ratio of 0.76. Here, they did a subgroup analysis looking at blood TMB with different cutoff, but really did not show any difference in terms of differential benefit in overall survival. They also looked at the PD-L1 IHC with different cutoff, was 1% and 5%. And again, here we did, and they looked at overall survival, the left in the PFS, did not really show any meaningful difference. If at all, PD-L1 negative groups seems to be benefiting a little bit more, but no really meaningful significant in statistical difference. They define long-term survivor as someone who lived more than 18 months. That's how they defined long-term survivor, and they really looked at the data to find atezo combo group have much more long-term survivors, and within those group there were no difference between the blood TMB and PD-L1. You can see that here, and really the subgroup who benefited looks like they're with less metastatic disease burden, and some of the large diameter, as reflected by the RECIST score, really is the predictor of a good response based on this multivariate analysis in this IMpower 133 population. So if you do subgroup analysis in patients who really made it to the maintenance and define that as a maintenance population, even in that subgroup, atezo combo seems to show statistical and clinically meaningful benefit, as you can see with hazard ratio of 0.59. So summary, first line atezolizumab plus carboplatin versus carboplatin showed hazard ratio of 0.7 to 30% reduced risk of death with decent p-value and median overall survival 12.3 versus 10.3 difference. This is the first trial to set the new standard of care for immunochemotherapy combination in small cell lung cancer frontline. There was no concerning safety signal observed. Clinical benefit in overall survival was observed regardless of PD-L1 IHC expression or blood TMB. And this was based on the updated follow-up of 22.9 months. And this is very unique to small cell, and this theme of biomarker not being a great predictor is being repeated in many small cell trials. This is in contrast to many non-small cell lung cancer trial where there seems to be more correlation with biomarkers. So conclusion, from both trials, chemoimmunotherapy combination followed by immunotherapy maintenance is now the current standard of care for frontline small cell lung cancer treatment, regardless of biomarker status. And here is two pivotal trials that we just discussed. And if you want to see the numbers of the updated version of both trials head-to-head, interestingly, Caspian reported 2-year landmark overall survival versus IMpower 133 did not report the actual number. They just looked at the 18-month survival. So you have different numbers, but if you kind of draw the line and try to figure out where they are, they actually look very similar. And hazard ratio, even with the follow-up, did not change much. The initial hazard ratio and the updated hazard ratio did not change really much. So they both remain as option for the frontline non-small cell lung cancer. So that is the end. Thank you for listening, and I'm happy to take any questions if there's any time for it later.
Great, thank you. I am going to move on with our second talk to Dr. Nisha Mohindra from Northwestern, who's going to talk about second-line small cell lung cancer.